Welcome back. In the intricate world of infant feeding, human milk really is kind of the gold standard, isn't it?
It absolutely is.
But, families sometimes hit situations where their own milk supply just doesn't meet their baby's needs.
Right,
And that leads them to
right.
explore options, maybe beyond the formal milk banks.
Exactly.
So for those of you listening, on the path to becoming an IBCLC, an International Board Certified Lactation Consultant, understanding the official guidelines around these, let's say, alternative practices, it's super important for what you'll be doing.
It really is. And what's fascinating here is how the Academy of Breastfeeding Medicine, ABM, provides such specific evidence-based guidance on this exact topic. So today we're doing a deep dive into ABM clinical protocol, #36. It's all about informal milk sharing.
Okay.
And our mission for you as aspiring IBCLCs is really to equip you with the knowledge you need to counsel families responsibly, safely, navigating these situations, which can be, delicate and very personal. You need to do it with confidence and compassion.
Okay, let's unpack this. Before we get into the detailed guidance, let's just make sure we're all on the same page. What exactly is informal milk sharing?
Good question. So essentially, informal milk sharing is the direct exchange of human milk between individuals. It happens outside the really highly regulated system of formal milk banks.
Right, outside the banks.
Yeah. And the ABM protocol actually helps us distinguish between, say, community-based sharing, maybe among friends, family, local networks you trust,
Okay.
and then internet-based sharing, which, as you can probably guess, brings a whole different set of issues and, frankly, risks.
Right, I can imagine.
And there's also wet nursing. Sometimes people call it cross nursing.
Oh, yeah.
This is where a non-biological child is directly breastfed by someone who isn't their mother. It's actually, an ancient practice. Still happens in many cultures, often within really close-knit communities or families.
So if we connect this to the bigger picture, why are we seeing more of this informal milk sharing, now in the 21st century? What's pushing families in this direction?
Well, it seems to be largely driven by this really profound and understandable desire that families have today to give their infants human milk, especially with these strong recommendations, exclusive breastfeeding for 6 months, continue for a year, maybe longer.
Those guidelines are pretty clear.
Exactly. So when a mother's own supply isn't quite enough, or maybe there are other unique situations, families often look for, every possible way to get that vital nutrition. And that leads them to explore these informal sharing networks.
That makes total sense.
Yeah.
So who are the people typically donating milk in these informal setups? The protocol mentions a few common situations.
Yeah, it does. The primary donors are often lactating women who just have more milk than their own healthy baby needs a surplus.
Okay.
Then you sometimes have mothers who have milk, but for some reason they can't give it to their own infant. Maybe because of a specific illness the baby has, like galactosemia.
Yeah.
That's that rare genetic thing where babies can't process a sugar in milk. And this one's quite poignant. It can also include mothers who've sadly experienced a perinatal loss, but still have a milk supply. They might choose to donate, perhaps finding some comfort in helping other families.
Wow. Yeah, that's powerful. So it's clear there are strong reasons why families do this, but what's the ABM's official take on it? Did they just give it a green light?
Oh, definitely not unconditionally, no. While ABM does acknowledge that informal sharing can benefit babies and families,
Okay.
they're also very, very clear that it carries potential risks, significant ones.
Right.
And the responsibility, this is key, ultimately rests with the donor and the parent or parents of the baby receiving the milk.
So it's on them to weigh the pros and cons.
Exactly. They have to carefully weigh the known benefits of breast milk against the possible health and safety risks. Things like, exposure to medications the donor might be taking or infectious diseases.
That's a heavy responsibility.
It is. And it's worth pointing out that major players like the FDA in the U.S., HMBANA, that's the Human Milk Banking Association of North America, and INBA, the European equivalent, they've all either discouraged informal sharing outright or strongly urged people to talk to a healthcare professional first.
Okay.
Which really highlights just how serious the potential risks are considered.
Yeah, that really lands the point. So given that ethical weight on the families, what practical steps does ABM recommend to make it safer, especially for you as an IBCLC guiding these really personal choices?
Okay, this is where it gets really practical. There are 2 crucial strategies ABM emphasizes. To maximize safety in community-based sharing, you need 1, thorough medical screening of the donor.
Right.
And 2, really strict, safe milk handling practices.
Screening and handling, got it.
But hold on, before we even dive into those details, it's absolutely vital to stress what ABM strongly warns against.
Which is?
Internet-based sharing. They say it's not recommended under any circumstances, period.
Wow, okay. That's unambiguous. Why is internet sharing seen as so much more dangerous? What makes it different?
Well, it's not just about, milk possibly arriving spoiled, though that happens. It's more fundamental. It's about a potential breakdown of trust and, frankly, control. Studies have actually shown that milk gotten through the internet is often way more problematic.
Oh, so?
It can show up thawed, spoiled, maybe contaminated with bacteria. But here's the really alarming part. Milk that's sold for profit online.
The profit motive.
Exactly. It might be adulterated, diluted with other things like cow's milk or even water just to increase the volume and profit.
Oh, no.
Yeah, think about that. A family trying to do the best thing could unknowingly give their baby an adulterated product. Or milk from a donor who isn't being honest about their health history because they want to make money.
That's terrifying.
It is. When profit enters the picture for something like human milk, those ethical safeguards can just vanish. Donors might not be fully transparent about their health, their medications, their social habits, and that drastically increases the risk to the baby. That's why ABM is so incredibly firm on this point.
Okay, that absolutely drives home the danger. So, understanding those risks, let's talk about the safer route. Community sharing. What does that diligent medical screening look like for a potential donor, according to ABM? This is need-to-know info for an IBCLC.
Absolutely essential. So the ABM protocol gives specific guidelines there in Table 1. First up is what they call the mother-to-mother screening process.
Okay.
Ideally, this involves a face-to-face chat or at least a phone call. You need to ensure the donor is in good general health.
Makes sense.
And crucially, only taking medications or maybe herbal things that are actually compatible with breastfeeding.
How do you check that compatibility?
Great question. The protocol specifically recommends using trusted, evidence-based resources. Your go-tos should be LactMed and Dr. Thomas Hale's Medications and Mother's Milk. These are the standard references.
Okay, LactMed and Hale. Got it. What about checking for infections beyond general health?
Right, infectious screening. You need to look at the donor's prenatal tests, and if they've had any postnatal tests, look at those too.
What tests specifically?
The donor mother needs to be negative for HIV human immunodeficiency virus, hepatitis B virus, and also HTLV1, that's human T lymphotropic virus type 1, especially if you're in an area where HTLV1 is more common.
Right, high prevalence areas. And what about social practices? The protocol is quite specific there too, isn't it? What rules someone out as a suitable donor?
Yes, very specific. The guidelines are clear. A woman is not a suitable donor if she uses illegal drugs or marijuana.
Okay.
If she smokes or uses any tobacco products that includes nicotine gum, patches, even e-cigarettes.
No smoking or vaping.
Correct. Also, alcohol limits. If she consumes more than, 1.5 ounces of hard liquor or 12 ounces of beer or 5 ounces of wine or 10 ounces of those wine coolers daily.
Specific limits there.
Yes. And finally, risk factors for HIV. If she is personally at risk or if she's had a sexual partner in the last 12 months, who is at risk for HIV?
Okay, those are very concrete points. So screening the donor is step 1. What about step 2? Safe milk handling and storage. That's just as vital, right?
Equally vital. Absolutely. For comprehensive guidelines on just storing milk at home, ABM points you to their clinical protocol number 8. That's a great resource in itself.
Protocol 8 for storage.
Okay. And the current protocol number 36 also talks about home pasteurization, specifically the flash heating method. Some families might consider this to add another layer of safety or reduce infection risk.
Right. How does it work?
Okay. So Table 2 in the protocol lays it out. You take about 50 to 150 milliliter of the donor milk, put it in a heat-resistant glass jar.
Glass jar, got it.
Then you place that jar into a small pan of water. Make sure the water level in the pan is about 2 fingers higher than the milk level inside the jar.
Okay.
Then you heat the water until it reaches a rolling boil.
Rolling boil.
And this is crucial. As soon as it hits that rolling boil, you immediately take the jar of milk out of the water.
Immediately. Don't keep boiling it.
Exactly. Then you cool it down quickly, maybe in a bowl of cold water or ice water. And make sure you protect the milk with a clean lid while it's cooling and when you store it.
Okay, and then it's ready to use.
Once it's cooled, yeah, it can be fed at room temp within about 6 hours, or you can pop it in the fridge or even refreeze it.
But there's a catch with pasteurization, isn't there? Something about the milk itself.
Yes, there is. And it's a really important point for families to understand. while flash heating does significantly reduce bacteria and many viruses.
Which is the goal, right? Safety.
Right, safety first. But you have to inform the mother, the recipient, that pasteurization can also significantly decrease some of the beneficial components in human milk.
Like what kind of components?
Things like immunoglobulins, those protective antibodies, and some of the live cells that are so valuable.
Okay. So it's a trade-off.
Yeah.
Reducing risk versus potentially losing some benefits.
Exactly. It's a delicate balance.
So as an IBCLC, how do you help families navigate that very personal decision? It sounds like it could be overwhelming.
It can be. Our role isn't to make the decision for them, but to present the facts clearly. Explain the pros and cons of pasteurization, the reduced infection risk, versus the potential loss of some beneficial components. We need to empower the family to make their own informed choice based on their comfort level with the risks they perceive versus their desire to preserve everything in the milk. It's about giving them the full picture so they can decide what feels right for them.
Providing the info, supporting their choice.
Yeah.
Okay, so pulling all this together, the risks, the screening, the handling, the pasteurization trade-off, what does this look like in practice for an IBCLC on the ground? How do we actually support families effectively?
Right. As an IBCLC, you're in this unique position as an educated healthcare provider.
Yeah.
You're really well equipped to help families make these informed choices when they're thinking about informal milk sharing.
So what specific things can we do?
Several key things. You can advise the recipient family on doing that comprehensive medical screening of potential donors. Help them understand all the contraindications, illness, meds, social practices.
Really walk them through table one, basically.
Exactly. You're also the ideal person to instruct both the donor and the recipient on those crucial safe milk handling and storage practices, maybe pointing them to Protocol 8. And maybe, most importantly, you constantly encourage truly informed choice. You have to keep emphasizing that the ultimate responsibility lies with the donor and the recipient parents.
Right.
Your role is to empower them with the knowledge and tools to make the safest possible choices for their baby.
Okay, so we've covered the theory, the guidelines. With theory is one thing, right?
Right.
How does this actually play out in real life with real families? Let's maybe try to bring this guidance to life with a few scenarios where informal sharing might come up.
Yeah, good idea. So picture this. A mother contacts you. She has tons of milk, way more than her own baby needs, and she genuinely wants to help another family she knows.
Okay.
As an IBCLC, you'd guide her through understanding the screening process herself, what health info is critical for her to share, checking her own meds using LactMed or Hale.
Right.
You'd also teach her the best ways to collect and store her milk safely. And maybe discuss pasteurization if the recipient family brings it up.
Okay, so supporting the donor side. What about trickier situations? Or maybe culturally specific ones?
Definitely. Think about those incredibly tough cases, like a family dealing with the grief of perinatal loss where the mother still has milk and wants to donate it.
Yeah.
An IBCLC would need to approach that with immense compassion, guiding the grieving mother through the ethical side, the practicalities, making sure her own well-being is considered, while also ensuring the process is safe if she does decide to donate.
That requires a lot of sensitivity.
Absolutely. And then there's wet nursing, that cultural practice we mentioned. If a family is considering having someone directly breastfeed their child,
Right.
the IBCLC needs to emphasize that the wet nurse needs screening just as carefully as any milk donor, maybe even more so given the direct contact.
Same rigorous standards apply.
Exactly. In all these diverse scenarios, the core job of the IBCLC is to apply these ABM guidelines, focus on informed choice, diligent screening, safe handling, basically, mitigate the risks while supporting the family's goals with solid, evidence-based information.
All right, IBCLC aspirants, deep breath. Let's see how well you've absorbed this. We've put together 10 multiple choice questions straight from ABM protocol to help you gear up for your exam. Ready?
Let's do it. Question 1. Which of the following modes of informal milk sharing is strongly discouraged by the Academy of Breastfeeding Medicine, ABM? A. Community-based milk sharing among known acquaintances. B. Wet nursing within extended family. C. Internet-based purchase of breast milk. Or D. Donation of surplus milk to a local milk bank.
Okay, think about that one. Which is strongly discouraged?
The correct answer is C. Internet-based purchase of breast milk.
And the rationale?
The ABM position statement is crystal clear. Internet-based breast milk sharing is not recommended under any circumstances, and they specifically add, especially the purchase of milk over the internet is strongly discouraged.
Got it. Question 2.
Question 2. According to ABM protocol, what are the 2 most important strategies to maximize the safety of community-based breast milk sharing? A. legal agreements and financial compensation for donors. B, medical screening of the donor and safe milk handling practices. C, only accepting milk from mothers of multiple children in formal pasteurization. Or D, anonymous donations and rapid delivery services.
This one's about those core safety pillars we discussed.
Correct answer. B, medical screening of the donor and safe milk handling practices.
Rationale.
The overview section of the ABM statement explicitly highlights these two. 1, medical screening of the donor, and 2, safe milk handling practices can maximize the safety.
Makes sense. Next.
Question 3. When counseling a recipient family about potential milk donors, an IBCLC should advise that a donor is not suitable if she A, consumes 3 ounces, 89 ml of wine daily. B, has a history of seasonal allergies managed with antihistamines. C, smokes or uses tobacco products, including e-cigarettes. Or D, is taking an antibiotic compatible with breastfeeding for a minor infection.
This tests your knowledge of the specific rule-out criteria.
Correct answer. C, smokes or uses tobacco products, including e-cigarettes.
Why?
Table 1, the screening guidelines, clearly lists that a woman is not a suitable breast milk donor if she smokes or uses tobacco products, including nicotine gum, patch, e-cigarettes. Remember, the alcohol limit mentioned was more than 5 ounces of wine daily, so 3 ounces is okay by that specific rule. And compatible meds are generally fine.
Right. Okay, number 4.
Question 4. A mother wishes to home pasteurize donated breast milk using the flash heating method. Which of the following is a critical step in this process as per ABM guidelines? A, heating the milk in a plastic container in a microwave. B, allowing the water to boil for at least 10 minutes after a rolling boil is achieved. C, immediately removing the jar of milk from boiling water once a rolling boil is reached. Or D, filling the glass jar to the brim with milk to ensure maximum heating.
This is about the specifics of that flash heating technique.
Correct answer. C, immediately removing the jar of milk from boiling water once a rolling boil is reached.
Rationale.
Table 2, the pasteurization guidelines, states exactly that. Immediately after the water comes to a boil, remove the jar of milk. It also specifies a heat-resistant glass jar, not plastic or microwave, and mentions heating only 150 milliliters, not filling to the brim, and specifically not boiling too long.
Okay, number 5.
Question 5. Which of the following infectious screening tests should a potential breast milk donor be negative for, according to ABM guidelines? A, varicella zoster virus, chickenpox. B, human immunodeficiency virus, HIV. C, Epstein-Barr virus, EBV. Or D, cytomegalovirus, CMV.
Direct recall from the infectious screening list.
Correct answer. B, human immunodeficiency virus, HIV.
And the reasoning?
Table 1 again. It specifies the donor should be negative for HIV, hepatitis B virus, HTLV1 in high prevalence areas. The others listed aren't part of that specific ABM requirement for donation screening.
Okay, halfway there. Question 6.
Question 6. The ABM position statement notes that home pasteurization, flash heating, of donated milk can have what effect? A, significantly increase the immunoglobulin content of the milk. B, eliminate all potential viruses without exception. C, significantly decrease some of the beneficial components of human milk. Or D, make the milk safe for consumption regardless of donor screening.
This revisits that important trade-off with pasteurization.
Correct answer. C, significantly decrease some of the beneficial components of human milk. Rationale.
The protocol explicitly cautions. However, the mother needs to be informed that pasteurization can significantly decrease some of the beneficial components of human milk. It doesn't increase immunoglobulins, doesn't guarantee elimination of all viruses, and definitely doesn't replace donor screening.
Right.
Question 7.
Question 7. According to ABM protocol #36, if families do use donor milk, providers should instruct both donors and recipients on A, advanced genetic testing for the infant. B, safe milk handling and storage practices. C, methods for increasing milk protein content. Or D, how to market surplus milk online.
What's the most practical core advice here?
Correct answer. B, safe milk handling and storage practices.
Rationale.
The protocol states very directly, regardless of the source, if families do use donor milk, then providers should instruct both donors and recipients on safe milk handling and storage practices. It even references protocol number 8 for the details. The other options aren't relevant ABM recommendations in this context.
Okay, number 8.
Question 8. An IBCLC is advising a mother who wants to donate milk. Which of the following would be a reason for the mother to be considered a suitable donor? A, she uses marijuana occasionally. B, she is taking a medication that is contraindicated for breastfeeding. C, she has surplus milk after feeding her own healthy infant. Or D, She recently had a sexual partner at risk for HIV.
This flips it around who is generally suitable.
Correct answer. C. She has surplus milk after feeding her own healthy infant.
Why that one?
The source document identifies typical donors as lactating women who have surplus milk after feeding their own infant. Options A, B, and D are all explicitly listed in Table 1 as reasons why a woman would not be a suitable donor.
Makes sense. 2 more. Number 9.
Question 9. In the context of informal milk sharing, who bears the primary responsibility for the donor milk exchange, according to ABM? A. The healthcare provider facilitating the discussion. B. The U.S. Food and Drug Administration, FDA. C. The Human Milk Banking Association of North America, HMBAAA. Or D. The donor and the parents of the recipient infant.
Where does the buck stop, according to ABM?
Correct answer. D. The donor and the parents of the recipient infant.
Rationale.
The ABM position statement couldn't be clearer on this. The responsibilities of donor milk exchange remain with the donor and the parents of the recipient infant. While providers guide, the ultimate responsibility isn't on them, nor the FDA or HMBANA in these informal exchanges.
Okay, last question, number 10.
Question 10. Which resource is specifically recommended by ABM for decisions on whether medications are compatible with breastfeeding for potential milk donors? A. WebMD and general internet searches. B. LactMed and Medications and Mother's Milk by Dr. Thomas Hale. C. Pharmaceutical package inserts only. Or D. Advice from online parenting forums.
This asks about those specific reference tools.
Correct answer. B. LactMed and Medications and Mother's Milk by Dr. Thomas Hale.
Now the rationale.
Table 1, under the screening guidelines, explicitly states, it is recommended that LactMed and Medications and Mother's Milk by Dr. Thomas Hale be used for decisions on whether medications are compatible with breastfeeding. The other sources listed are not considered reliable or comprehensive enough for this critical assessment.
Okay, 10 questions down. So what does this all mean for you, our listeners, the aspiring IBCLCs? Our deep dive today into ABM Protocol #36 really, I think, highlights just how complex informal milk sharing is. It's definitely not a simple yes or no situation. It's much more about a nuanced approach that always prioritizes the baby's safety and, importantly, truly informed parental choice.
Yeah, and this raises an important question for every one of you preparing for your career. How do you actually take this detailed knowledge we've discussed and apply it effectively, with both compassion and that necessary clarity in real situations? Because knowledge is really only valuable when you can understand it and then apply it. So when you encounter a family who's considering informal milk sharing, your role is to be that calm, knowledgeable guide. You walk them through the evidence-based screening, the vital handling practices, the risks, the benefits, being committed to continuing your own learning and adapting your counseling to each unique family. That's going to be absolutely essential for providing the safest, most supportive care you possibly can.
Exactly. We really hope this deep dive empowers you to feel more confident supporting families, whatever their infant feeding journey looks like. Even in these less common scenarios, those core principles, safety, transparency, informed consent, they absolutely have to stay front and center. Maybe take a moment after this to reflect on how understanding these guidelines really does strengthen your ability to advocate effectively for the health and well-being of the babies and families you're going to serve.